Kia ora, I'm Dr. Helen Fulcher from the Goodfellow unit, and I'm speaking with Brian Betty, who's a general practitioner in Porirua and the medical director for primary care for PHARMAC. Hi, Brian.
Hi, Helen. How are you?
Now, you've got a fantastic topic that we're really interested in, but most of us don't know much about biologics. Can you talk a little bit around what you're educating us on today?
So biologics are this very new class of medication that has emerged over about the last decade, two decades. Absolute game changers in conditions such as rheumatoid arthritis, inflammatory bowel disease, and obviously cancers. And these are medications that work to treat these diseases. And rheumatoid arthritis is a really good example of it. I mean, I think we've all had examples of patients in the past who have been inadequately treated for rheumatoid arthritis, got the nailed up fingers, crunched over, in pain, not able to do much. It's really, really interesting now with these new biologic medications. We very rarely see that type of thing developing. So they're an absolute game changer in terms of what they do and how they do it. There is a problem with them. They're very expensive. And we've seen that recently in the public with things around Keytruda and various other melanoma medications. So there's always a tension between the funding of these medications and their access in the marketplace. So it's a really, really interesting developing topic that GPs need to be aware of. I suppose the other thing I'd say about it, what is very, very interesting about these medications, in the latest data that we've got at PHARMAC, about 50% of scripts are actually written by GPs and not specialists.
Right.
So repeat scripts are being written by GPs and monitored by GPs going forward. So it's incredibly important for GPs to understand what these medications are and the things to look out for when they are seeing patients on these medications.
And the most common ones that we are seeing in primary care, you've mentioned Keytruda, which we obviously have seen and heard about before. What are the other ones that we should be looking at?
Well, I suppose it's the rheumatoid arthritis ones are actually very common, or inflammatory bowel disease. Okay, so those are your adalimumabs, your Enbrels, your Humiras. These are the injections that the patients give to themselves weekly or however often, and the patients will come in often asking for a script. Again, very good at treating the disease, but certain issues with them. In fact, they're immunosuppressants. That's how they work. So they reduce the inflammatory response. And in doing that, there's certain things we need to be aware of. Obviously, if a patient comes in slightly unwell or whatever, we need to be thinking of more serious infections sometimes, especially with pneumonias, which may be masked on these medications. I think clinically there's some implications for that.
Those patients, should we be screening them if they're on those drugs then, or should we just be capitalising when they come in?
I think we need to be clinically aware. And I suppose the biggest example, I've seen a patient a few months ago that presented on one of these drugs and presented with just a persistent cough, low-grade temperature, and blood count wasn't particularly raised but did turn out to be a pneumonia. So we've got to have a high degree of suspicion for things like that, and a high degree of suspicion to maybe contact the specialist to chat it through as to about appropriate management if the patient does become unwell.
So it's the awareness that they're immunosuppressed, they're more at risk. As you say, being clinically aware, if every consult that you see them if they're slightly unwell, that may be related.
It's just a degree of suspicion and just having that at the back of our minds. Most of the time it's not an issue, obviously, as with most medications. The other thing that's really, really interesting with these medications is they're produced in a different way, and that's why they're called biologics. So our traditional medications we call chemicals. So if we get a generic for metformin, for instance, it's an identical molecule that's presented. Biologics are produced, essentially the closest I can think of it is like beer vats. So they're produced with yeast and a whole lot of biochemical stuff, which I don't quite understand, DNA modulation, so that every batch that is produced is slightly different. You can't get two identical batches. Like if you produce milk from one herd of cows versus another herd of cows, there's going to be slight variations, and this is one of the things we see with biologics. Now, the actual problem, or not the problem that can develop as a result of that, they can develop what we call neutralising antibodies. So you can get these antibodies to the biologics themselves because of these small changes that occur and the body reacts to them. So over time their effectiveness can actually diminish or wear off. And that's another thing that's become very obvious with these medications over time.
And what do you see, I guess that depends on each disease, but what do you generally see as they start to wear off or their effectiveness diminishes?
Well, it's the effectiveness of the disease. So
Yeah.
if they've got psoriasis, the psoriasis is starting to pick up a little bit. Maybe the rheumatoid arthritis isn't as well controlled. So I suppose medicine or practitioners still trying to work out how to deal with this, how long, when to start them, how long they should be on them, should we be switching through them, how should they be managed, is really a bit of an evolving science.
Do you have drug holidays with these?
There's a lot of debate about whether you should or shouldn't. I suppose the debate is around, does it prolong the life of the biologic they're using, or does it actually prime the immune system to produce more of a reaction? So I think that whole debate is really sort of not
resolved.
Not resolved. So there's a lot to learn about them.
And is there quite a lot of evidence around the benefit of them lengthening life or lengthening health life expectancy?
I think
guess.
quality of life,
Yeah.
I think, is the key thing, isn't it? So it's the quality with which a patient lives and long-term consequences of a disease. So absolute game changers in terms of what they do.
Yeah.
And very, very positive. But again, I think are going to move more and more into the GP arena in terms of prescribing and monitoring these medications, because obviously specialist services, and we now know there's about 11,000 people on these biologics for rheumatoid problems and dermatological problems in New Zealand. And if we look back 3 or 4 years ago, that number was about 5,000. So it's increasing rapidly. More and more GPs are going to have to be monitoring and looking at these medications and looking out for the consequences and being aware of how they work and the issues around them.
So where do GPs or primary caregivers find the information that they need to? So if they have a patient that comes in on a drug they're not really understanding very well, where do they go to? Who do they talk to?
Sure. Look, online resources, actually a very good article by BPAC.
Yeah.
If they just look under biologics in BPAC, it was funded by PHARMAC, very good summary of the biologics and how they work and the issues around them. I think that's probably one of the best sources to tap into.
Great.
I think talking to specialists, if you have patients, about the medications and things to look out for is really, really important. And obviously things like Goodfellow and
at the conferences and hearing you talk.
Yeah, absolutely.
Fantastic, Brian. I think there's a lot of information that is going to be learnt for everyone around these new lot of drugs. So good luck.
Good.
Thank you.